Good morning, I am Dr. Lara Camilleri, and today I will be presenting my research on driving in dementia. With an aging population worldwide, the number of elderly drivers is also increasing. Driving is important in our daily life since it provides us with independence, freedom of movement, and a greater chance of socializing. However, driving can be a dangerous weapon in the hands of the unskilled driver. In fact, driving is a complex task affected by various intrinsic and extrinsic factors, and dementia is a condition associated with old age that might influence these factors. Moreover, the true proportion of drivers with dementia is difficult to assess. However, driving cessation is not without consequences. Therefore, the main aim of driving assessment in dementia is to balance the risks of continued driving versus those of driving cessation. The main risks of driving in dementia include motor vehicle accidents, which can be a danger to the patient, passengers, other drivers and pedestrians, and also the risk of getting lost. On the other hand, one should consider the implications of driving cessation, including the risk of social isolation, supports available from relatives and friends, access to amenities, the use of public transport, and the risk of institutionalization. However, decisions of driving assessment may also be influenced by the driving laws and guidelines available. There is a lack of consensus on driving guidelines with regards to assessment methods and license review periods, and laws on driving in dementia also vary from one country to another, and are sometimes inexistent in some. Moreover, license renewal often require a medical certificate from fitness to drive, which is often done by the general practitioner, but sometimes referrals can be done to specialists as well. The aims of this study include the following: to identify driving behaviors in dementia, to assess whether the dementia stage and subtype influence driving capacity, to identify different types of driving assessment tools used in patients suffering from dementia, to assess the accuracy of different driving assessment tools at predicting driving capacity in different stages of dementia, and to assess the accuracy of different driving assessment tools at predicting driving capacities in different types of dementia. This study design was a literature review, but we used the PRISMA checklist for systematic reviews. The search method was divided in 3 stages. The first stage was a broad online search from 4 databases. The second stage included an incremental search by reviewing the reference lists of related literature reviews, systematic reviews, and meta-analysis to identify any articles that were missed in the initial stage. And stage 3 involved the application of inclusion and exclusion criteria. For the quality appraisal, we used various tools as shown in the slide. The following is a flow diagram of the literature search, and we were left with a total of 48 articles that were included for quality appraisal and analysis. From the 48 studies, 44 were primary observational studies and 4 were systematic reviews with meta-analysis. None of the articles were discarded based on quality assessment, since this is quite a subjective process. The pie chart shows the quality analysis of the articles, with medium quality being the most common one. Results were then divided into driving behaviors and driving assessment. So first we're going to go through driving behavior. Compared to healthy controls, drivers with dementia had higher driving test failure rates and overall higher error scores, were more likely to commit serious errors, drove fewer miles per week, but driving frequency was not associated with driving performance, and had a statistically significant reduced awareness of their self-driving ability. This table shows the driving behaviors in dementia identified from articles and their frequency. The most common errors were problems with route learning and following, inappropriate reaction to traffic stimuli, impaired reaction time, and problems with backing up. These were followed by poor speed control, landmark sign identification, lane maintenance, and maneuvering turns and intersections. When assessing the impact of the stage of dementia on driving behaviors, results varied according to the test used to quantify the dementia severity. For instance, in all 3 studies using the MMSE, increased dementia severity quantified by a lower score was not significantly correlated with a worse driving performance. On the other hand, the 6 studies that used the CDR score, increased dementia severity quantified by higher CDR levels was consistently related with worse driving performance. 3 of these studies included dementia participants with moderate severity, quantified by CDR score of 2, and all these patients were unsafe drivers. With regards to behaviors in different types of dementia, only 5 observation studies included dementia subtypes other than Alzheimer's disease. In general, Alzheimer's disease, mixed dementia, and frontotemporal dementia patients made primarily tactical errors, whereas vascular and Lewy body or Parkinson's dementia participants committed both tactical and operational errors. The operational errors in these types of dementias is expected considering the early motor symptoms associated with these diseases. Moreover, vascular dementia participants had the highest rate of driving errors and difficulties amongst all the groups. The table shows the driving behaviors according to the individual dementias. Driving behaviors that were common to all subtypes included lane maintenance errors, speed control, no observation of blind spot, unsafe lane changing, unsafe merging with traffic, poor traffic sign recognition, and inappropriate reaction to traffic stimuli. With regards to frontotemporal dementia, they were mostly to disregard other drivers or cyclists or pedestrians around them. Now we're going to move on to driving assessments in dementia. These were the types of assessments identified. They were divided into 3 main categories. First, on-road assessment, which included both standardized road assessment and naturalistic driving. Simulated driving assessment and office-based assessment, including neurophysiological tests and clinical interviews. The first comparison was on-road driving assessments. In general, standardized on-road testing is an accurate mode of driving assessment in dementia. It is reflective of naturalistic driving behavior when considering global performance. However, results varied when considering individual behaviors, but in general, road tests that stress proper lane keeping and response to traffic have standardized weighting for each item and are held in the patient's environment may be more representative of naturalistic driving. With regards to simulated driving, a statistically significant correlation was found between on-road tests and simulated driving in participants with AD dementia, but not in participants with non-AD dementia. With regards to clinical interviews, clinician rating was more accurate than caregiver rating, and caregiver rating was more accurate than participant self-rating. Another comparison was between the neurophysiological tests and on-road driving assessments. There were a lot of neurophysiological tests that were identified, and obviously I cannot go through all of them in this presentation due to time constraints, but the 3 most common tests that were mentioned were the trail-making test B, the MMSC, and the trail-making test A. With regards to the trail-making test B, No study used score cutoff points, and 66% of these found a significant correlation between the test and on-road driving assessments. With regards to the MMST, only 46.7% of the 15 observation studies found a statistically significant association, and only one study included cutoff scores, where a cutoff score of 19 yielded a sensitivity of 42% and a specificity of 89% in predicting unsafe driving in dementia. With regards to the trail-making test A, 90.9% of the studies found a statistically significant correlation between the two, and correlation ranged from moderate to high. When comparing the two types of in-office-based assessments, neurophysiological tests were more accurate than caregiver or participant rating at predicting fitness to drive in drivers with AD dementia. Driving assessments according to dementia severity, none of the studies assessed the predictive value of neurophysiological tests according to dementia severity. On-road assessment was used in 3 studies, which yielded inconsistent results. Simulated driving was used in 2 studies, giving also inconsistent results. And 1 study compared the predictive accuracy of driving safety between physician informant and participant rating with on-road testing. It found no significant difference between both assessments, very mild and mild AD groups. With regards to dementia etiology on driving assessment, only 6 studies included non-AD dementia participants, while the other studies included only AD dementia. In general, the predictive accuracy of different driving assessment methods was affected by dementia subtypes. This table shows the number of studies which found a statistically significant correlation with regards to the predictive accuracy between the type of dementia and driving assessments. On-road assessments were found to be most accurate in all subtypes. So, if there is a concern that is expressed during the clinical interview, one should refer for on-road driving testing. Timing of driving reassessments. Only 3 studies explored the longitudinal relationship of driving competence in dementia. All 3 used standardized road tests. These concluded that a higher CDR score indicating higher disease severity should prompt driving assessments, and a 6-monthly reassessment period for those who passed the initial assessment was recommended. We also compared cognitive domains with driving behaviors and assessments. So, attention, visuospatial skills, and executive function were predictive of most driving behaviors. In addition to global cognition, these 3 cognitive domains were also predictive of driving safety and collision risk. With regards to the correlation between cognition and driving assessments, 3 meta-analyses explored this correlation. 1 meta-analysis used only on-road testing as an assessment measure, whilst the other 2 used a combination of driving assessments. In general, they concluded that executive function, memory, attention, and visuospatial skills were the most accurate predictors of driving performance. Conclusion. A set of conclusions were drawn, including that dementia affects driving performance. Attention, visuospatial skills, executive function, and global cognition are associated with driving competence and fitness to drive. Dementia disease severity affects driving performance. Higher disease severity is associated with a greater risk of unsafe driving. Moderate to severe disease, quantified by a CDR score of equal or more than 2, is not compatible with safe driving. Inconsistent results were drawn with regards to driving safety in very mild and mild disease. Disease severity should not be an absolute contraindication for driving in mild disease stages, but screening, formal assessment, and regular follow-ups may still be indicated. Driving reassessment in dementia should occur at intervals of 6 months. The dementia etiology affects driving performance in different ways. Rote assessments are reflective of naturalistic driving and should be considered the gold standard for driving assessment in dementia. Driving simulators are comparable to on-road tests for assessment of fitness to drive in AD dementia but not in a non-AD dementia. Participant and caregiver rating have a limited role in determining fitness to drive in dementia, but negative results are more reliable than positive ones. Neurophysiological tests play a role in assessing fitness to drive in all types of dementia. However, no one test has been identified as being predictive of fitness to drive. Instead, a combination of tests aimed at assessing multiple cognitive domains should be used. So, what are the implications of the study on future research? Most conclusions of grade D evidence. In fact, there is a lack of standardization in driving assessments worldwide, and different driving assessment tools have unique advantages and disadvantages. Evidence on the effect of dementia severity on the predictive accuracy of driving assessment tools is also lacking. Dementia is a progressive disease, so longitudinal studies would be ideal to assess the progression of fitness to drive, the effect of disease severity on driving safety, and the optimal reassessment intervals. Research on driving behaviors and assessments in drivers with dementia of the non-AD subtype is lacking and of poor quality. Dementia is associated with loss of mental capacity in later stages, so discussion on driving cessation is advisable in early disease stages. Unfortunately, research on compensatory strategies for driving in dementia is also lacking. In conclusion, research on driving and dementia is scarce and of questionable quality, so its application in clinical practice is limited. Therefore, as anything in geriatrics, an MDT approach, a comprehensive geriatric assessment, and a patient-centered care is advisable.